Dear friends, it is almost time to start. We're going to give a couple of more minutes. As always, as we always start with the good morning, good afternoon, good evening, because we do have friends from all around the globe, and it's great to have you all in this fantastic session. As you all know, this is another special monthly webinar. This time, the International Pediatric Ophthalmology and Strabismus Council has partnered with the Association for Ophthalmology and Strabismus in Russia, and we will cover various aspects of restrictive strabismus and strategies for management. So we're going to be silent for maybe another minute, just to allow everybody to be settling in and logging in. Then the session will be kickstarted with Dr. Balasanyan. My co-moderator, Igor, could not attend this morning, but we have lovely Victoria.
Hello, everyone. Nice to see you again. Faruk, we had already have 137 members. We will wait a little, I think, and start in a minute. I think we can start. So we start our joint meeting, IPOSC-AOS webinar. And let me introduce the moderator, speaker, and chair of webinar, Dr. Professor Faruk Orge, President of International Pediatric Ophthalmology and Strabismus Council, William and Margaret Althans, Chair and Professor in Pediatric Ophthalmology, Director and the Fellowship Director of Pediatric Ophthalmology and Adult Strabismus in Rainbow Babies and Children's Hospital, and Professor of Ophthalmology and Pediatrics, President of International Pediatric Ophthalmology and Strabismus Council. Faruk, nice to see you again. And we start.
Well, thank you again, Victoria, one more time. It is a pleasure. IPOSC is honored to be a part of this now monthly meetings that we're having. This is our fourth webinar, and we'll be continuing. And thank you all for joining one more time. As you know, IPOSC is representing more than 85 member societies and 19,000 individuals. One quick plug in, the IPOSC International Classification for ROP has been published, and it is available for everyone. We've learned quite a bit thanks to the amazing committee of 34 international ophthalmologists who made that possible, along with our members. So that's just a quick plug-in for that. With that, I'm going to quickly introduce the amazing Professor Asnorian. So Igor could not be with us, but well, he is with us in many ways. So he is the founder and head of Vyazny Vizor Children's Eye Clinics in Russia. He's the academician of the Academy of Medico-Technical Sciences, also the president of Association for Ophthalmology and Strabismus in Russia. With that, I would like to go to his introduction.
Добрый день, дорогие друзья. Здравствуйте. Я счастлив вас всех приветствовать. Счастлив, что мы снова вместе с вами. Я хочу особо поприветствовать наших замечательных спикеров. Фарук, здравствуй. Здравствуйте, Сейхан. Здравствуй, Тамара. Здравствуй, Ольга. Здравствуй, Наталья. Здравствуй, Виктория. Это такой, знаете, красивый, великолепный цветник, букет лучших стробизмологов и самых замечательных людей. Вот сегодня представлен на нашем вебинаре. Я думаю, что это очень большой и замечательный почин, когда, значит, самые передовые ученые в области стробизмологии собираются и передают свой опыт в разных странах. Уверен, что в наше время, сумасшедшее время, когда все кругом, когда все ходят как по минному полю, наш вот этот замечательный союз, который сформировался в IPOSC, это один из оазисов такой, знаете, стабильности, любви, профессионализма и взаимоподдержки, и взаимопомощи, за что всем большое спасибо. Наша организация офтальмологов-стробизмологов России, она сформирована уже 5 лет и функционирует. В ней уже более 1000 человек. Это ведущая организация стробизмологическая, такая общественная, которая на сегодняшний день имеется в России. И, соответственно, имеет очень большой, как мне кажется, потенциал дальнейшего развития. Интерес к стробизмологии в нашей стране благодаря этой деятельности становится все шире и шире. Количество людей, офтальмологов, молодых офтальмологов, которые входят в свою профессиональную жизнь, их количество тоже увеличивается, тех, которые выбирают стробизмологию, и это очень радостно. Дорогие друзья, еще раз большое спасибо вам за участие, большое спасибо за присутствие. Позвольте передать вам глубочайшее уважение и любовь. И я хочу пожелать нашему сегодняшнему вебинару успеха, удачи. Не сомневаюсь, что он будет интересен и пройдет великолепно. Спасибо вам всем.
Oh, dear Igor, it's always great to have you. With that, I would like to also introduce our moderator and speaker, Dr. Victoria Balasanyan. From Russia. She is the Deputy Head of Scientific and Clinical Affairs of Vyazny Vizor Children's Eye Clinics, Head of the Surgical Department of the same institution, and as well as the Vice President of Association for Ophthalmology and Strabismus in Russia. So it is great to be co-moderating with Victoria. We would like to quickly now, I'm going to have Dr. Seyhan Ozkan share her screen. Such a delight to have Seyhan with us.
Thanks, Faruk. Shall I start?
If you can share your screen, please. Yes.
I have already shared. Okay. Can you see it?
We do not see it yet.
Okay. Let me try once more.
Sure. Perfect. Now we have it. And okay. So it is my distinct pleasure to introduce Professor Dr. Seyhan Ozkan from Turkey. She is a professor of ophthalmology and director of Pediatric Ophthalmology and Strabismus Department in Aydın Adnan Menderes University Medical School in Aydın, Turkey, currently in private clinic in Aydın. She is the past president of European Strabismological Association also the past president of International Strabismological Association, and she's a member of ICO Leadership, Development and Society Relations Committee. She is well known to all of us, and we've learned and continue to learn from Seyhan. So it's great to have you, Seyhan. It's all yours. Thank you.
Thanks, Faruk, for this very kind introduction. And I'd like to thank for this kind invitation. And it's my great pleasure to be at this meeting. So I have no potential conflict of interest to disclose. Well, we all know that the aim of strabismus surgery is to correct ocular misalignment and to keep the eyes aligned in 9 positions of gaze. However, strabismus surgery itself may be the reason for misalignment and limitation of ocular motility. And during this talk, I will mainly focus on the potential reasons, preventive measures, and treatment of post-op restrictive problems. So when we see any motility problem after surgery, we need to decide whether this is due to an excessive recession or slippage or disinsertion, or whether it's due to a restriction. So in order to find this out, we may use forced action tests, forced generation tests, IOP change in gaze positions, or saccadic velocity measurements. So the problem that causes a restricted ocular movement may be the muscle, conjunctiva, soft tissues surrounding the muscle, or the orbital soft tissues. So in order to find this out, we need to do the forced action test at all steps of surgery and even after severing the extraocular muscle, which indicates orbital fibrosis. So Jampolsky described the leash and reverse leash effect. So this indicates that the tissue that causes a restriction may limit the rotation both in the opposite and in the same direction. So if we go through the etiology, it is the majority of those problems are excessive shortening or tucking of extraocular muscle, inadvertent capture of neighboring oblique muscle, transposition surgery, or formation of adhesions and scar tissue. For resections, the preventive measure is not to exceed conventional amounts and not to resect tight muscles too much, and using adjustable resections where possible, and to check the forced action after resection. So the management of too much resection is to recess the resected muscle, or in severe cases, some tendon elongation procedures may be performed. And botulinum toxin A can be very useful when it is used, especially during the early post-op period. So this is one of our patients. This child has cerebral palsy and Parino syndrome with a severe abnormal head posture. And she underwent supraplacement of horizontal rectus muscles in both eyes with a right small recess resect procedure. However, the next day was not a good day for me. As you can see here, there was a huge overcorrection. There's a consecutive exo with significant limitation of adduction. So I thought that the medial rectus muscle was slipped. So I reoperated her. However, to my surprise, I've seen that the forced action test was +4 positive on adduction. There was no problem in medial rectus area. So I neutralized the resected lateral rectus by recessing it for 5 millimeters, and forced action test was negative. However, after second surgery and post-op first week, you can see there is still significant exotropia with limitation of adduction. So this shows that this patient has an abnormal contractility problem. So this may be the case in CP patients, similar to the into the skeletal muscles. So we've suggested to inject toxin into the right lateral rectus muscle. And this is how she reacted after toxin injection, and she remained stable in that position. So in reoperations, re-resecting a muscle is a problem because the previous amounts of resection may not be known, and there's no reliable data how much to re-resect an extraocular muscle. So the amount of resection should be determined depending on the forced action test during the operation. So in reoperations, another problem are the muscles with lost, slipped, or excessively recessed muscles, or the muscles with stretched scars. So these muscles shortens and become stiff. So advancing such a stiff and contractured muscle may end up with significant restriction of ocular motility, and the amount of advancement needs to be decided upon forced action test. So this is one of our patients with a right consecutive exotropia with slipped medial rectus muscle, and on surgery we have found that, and the stretch scar was also the case. So both the empty capsule and stretch scar was excised, and the muscle was advanced with the lateral rectus recession on adjustables, and after adjustment, and she had this micro esotropia and everything was fine. However, she came back on post-op second week with this consecutive esotropia. So these long-standing contractured muscles may react like that, and also the adhesions contribute for this. So we prefer to inject toxin into this medial rectus muscle, and this is how she looked 1 week after toxin injection. This is the overcorrected period first, and then afterwards, in post-op 9 months, she remained stable. So toxin balanced the contractile force in the early post-op period permanently. So excessive TAC is maybe a cause of restriction in superoblique surgery. It may end up with Brown syndrome. So the preventive measure is not to TAC the superoblique muscles if there's no tendon laxity. And forced action tests should be done during TAC surgery. So in congenital cases, this is one of our cases who underwent right inferior oblique disinsertion plus superoblique TAC surgery. And after TAC surgery in post-op 2 weeks, you see the brown effect in the right eye. So that amount of brown effect is not a concern. It resolves in time. Then you can see the appearance in post-op 9 months. However, if you do this surgery in an acquired case, this is a patient who had TAC surgery 10 years ago elsewhere, and you see that this brown effect is there. It never resolves. So if you're going to resolve this, if you are going to remove the TAC, you need to do it as early as 1 week. Otherwise, it is an irreversible surgery. So capture of neighboring muscles may develop during lateral rectus muscle surgery, and the inferior oblique may be captured, and the prevention is actually a very simple step. The lateral rectus must be hooked from the superior quadrant under direct view. So transposition surgery is another group of common surgery that causes some restriction. So the preventive measures are keeping parallel to the spiral of TO, and the augmentation sutures should be placed symmetrically. And if you're doing an Ishida transposition, again, your sutures must be symmetric. And if the forced action test is positive, then recessing the transposed muscles was recommended by Rosenbaum. So this is one of our patients with a left 6-nerve palsy. This patient did not have any medial rectus weakening, so she underwent augmented transposition of vertical rectus muscles. And this is the post-op appearance, and you can see that there's a small exo deviation. So considering that there was no weakening of medial rectus muscle, this patient shows the restrictive effect of transposition surgery, but for this amount of restriction is something that we aim to have after surgery. So this patient has again a left 6-nerve palsy, and he underwent a Nishida transposition into the in the left eye, again without any medial rectus weakening. And here you see the post-op 3rd Mart appearance, and you can see that there's a restriction on adduction related to Nishida transposition. There's a small exo. So this is something that we want to see for this patient, but we need to know this effect of transposition surgeries. Another transposition is inferior oblique anterior transposition, which is a common surgery, which may end up with anti-elevation syndrome. So the preventive measure is to suture the inferior oblique muscle in a bunched up fashion and not to exceed the inferior rectus insertion site. So if we go through the adhesions related to surgery, these adhesions may be at conjunctiva, tenons, intermuscular membrane, extraocular muscles, sclera, and if it is in the orbital fat tissue, this is called as adherence syndrome. So Parks described this syndrome as penetrance of posterior capsule, and there's a surgical disruption of orbital fat, and it typically occurs in inferior oblique surgery, but it may occur in all rectus muscle and other oblique muscle surgeries. There's a loss of elasticity of the septa in the extraconal space. So the preventive measures is essentially non-traumatic surgery with good control of hemorrhage, not to do too deep dissection, avoiding blind hooking, not to penetrate the posterior Tenon's capsule, and the materials and drugs to reduce adhesions and scarring. And here you see the inferior oblique surgery steps. So the major mistake that can be done is to penetrate the inferior oblique, the hook's tip from the posterior point. So the tip of the hook should be severe, just adjacent to the inferior oblique muscle. In superior oblique surgery, again, the posterior fibers should be hooked under direct view. So we prefer to hook this superior oblique tendon from the scleral side to be safe. Here you see a list of materials and drugs to reduce the post-op scar formation, and among those we have studied with Sepra film in an experimental model. So the treatment of adhesions is basically to release and excise scar tissue and to recess the appropriate extraocular muscle and conjunctiva if it is necessary, and to use one of those materials and drugs, or to use botulinum toxin during the acute phase. So this is the patient that we originally described the use of toxin for adherence syndrome. This patient has a right superior oblique palsy and underwent superior rectus recession and inferior oblique disinsertion. During surgery, tiny fat cells were recognized, and he was okay after adjustment, but he had a food poisoning and had a severe vomiting attack on post-op third day. And afterwards, he came back with this consecutive hypotropia with orbital fat tissue under the conjunctiva. So at this stage, any surgical attempt will make this patient worse. So this patient apparently was developing an adherence syndrome. So we've injected toxin into the right inferior rectus muscle in order to elevate this eye. So this here you see the 1 week after toxin injection, the underaction of inferior rectus muscle, and this is 2 months after toxin injection, and this patient remained stable afterwards. So the effect is similar to a traction suture. So the mechanism here is when there's an prolapse of orbital fat tissue, this inflammatory reaction grows and pulls the globe. So if the eye is kept in primary position by injection of toxin, then this attachment attached to the globe at point B instead of point A, which is a more posterior point. So in chronic phase, we need to know that once the integrity of facial system is lost, it's not possible to cure it, and all surgical attempts create new adhesions, and the goal is primary position alignment. So the take-home message is prevention is far more important than treatment, and the restrictions due to soft tissue scarring are more complicated problems than extraocular muscle-related restrictions. And botulinum toxin may rescue a restriction in acute phase, and we need to do the forced action test at all steps of surgery before, during, and at the end, and it should be a routine in all strabismus cases. I'd like to thank you for your attention, and I'd like to remind the next ISA meeting in Mexico, Cancun. Thanks very much.
Well, Seyhan, it was, as always, fantastic. So many pointers. Again, the prevention is the key. I just want to ask you a couple of questions while reminding everybody, if you have questions, please go to the QA or the chat pod to let us know your questions so we can discuss them lively. And Seyhan, you mentioned many of the prevention. That's very important. And have you seen a trend over the years that I have a suspicion that I think not only the strabismus surgeons, other surgeons, other ophthalmic surgeons have a better understanding on orbital and ophthalmic tissues. Do you think the rates of these problems have been a little bit lower than before, or do you see it as frequent as before?
Well, I must say that it is as frequent as before. And yeah, well, we actually recommend to use surgical microscope and to at least to lessen those problems. But in most of the places, the magnification is not used. And on the other hand, and if any person who is not familiar with the anatomy of those structures, please just do not do this surgery. Strabismus surgery is not a simple surgery, and even Excessive hemorrhage due to the problems with your general anesthesia may end up with significant problems, significant restrictive problems after surgery. So it is a problem of with all aspects, starting from the anesthesia, starting from your instruments, and starting what you're doing. And on the other hand, you cannot do a surgery just by looking at the tables. So even in a standard patients, you may see that the muscle is tighter than you expect in a non-restrictive concomitant strabismus. So you may need to design your surgery depending on the surgical findings.
And again, just to underline, anesthesia and obviously even control of the blood pressure during the surgery will affect the bleeding and different tissues, even prolapsing anteriorly to get in your way. That has been a problem. I just want to also ask you about the Botox that you do inject. Do you always use the same amount, as well as how far out do you think? You said it works in the acute phase. What is the longest phase that you had to go in and that you thought it worked?
Well, I must say that I've used botulinum toxin also in late phases as well, in patients who had restrictive problems after retinal detachment surgery. And I've got good results. So, but this is, is supposed to be, there is some paralytic component as well in those patients. And so this is a different group. So considering its effect in strabismus surgery, the main thing is when it is done during the wound healing period, other than rebalancing the length tension problems, the tissue attachments needs to be in a different place. So when you provide by moving the globe in another direction, as I've tried to demonstrate with some schematic representations, I'm sorry, they are very simple representations that I've done by myself. But when you keep the eye in a certain position, and if such adhesions attach to the globe in a certain direction, then its effect on limiting ocular movements is entirely different. So that's why it is important to do the injection before these soft tissue attachments develop permanently. Afterwards, you may have some length tension change in the muscle, but regarding the soft tissue structures, you need to be quick. And for the other question, I use the dose of 5 units. It is standard, yeah.
Thank you. And I think the pictures were fantastic, personally. Because I do not see any English questions, but I just want to make sure that, Victoria, are there any questions from the Russian audience? You are muted. Victoria, we cannot hear you. If you can unmute yourself.
Yes, we have some question in chat for Jonas regarding the Botox injection for the consecutive esotropia or exotropia. In your cases, will you continue to do the injection every 3-4 months? If yes, for how long?
So for congenital, I think the question is about congenital ESO and exotropia, so which is actually not related to this topic, but just as a brief answer, I can say that for this group of patients, botulinum toxin is not a method to re-inject in a periodic way. In this group of patients, the aim of using botulinum toxin is to provide a permanent cure. If you cannot provide a permanent cure, there is no point to re-inject for many times. So doing regular injections is a method for adults, let's say, who had secondary strabismus and who had 3 operations and so on, but wishes the eyes to be aligned.
Thank you. And with that, I would like to keep going, and so that we go to our next speaker. But please continue to ask the chat and use the chat pod and the QA for the questions, and then I'll hand it over to Victoria to introduce Dr. Zhukova.
Okay, with great pleasure, I want to introduce Professor Olga Zhukova from Samara. She is professor of the Department of Ophthalmology, Chief Pediatric Ophthalmologist for the Volga Federal District of the Ministry of Health of Russia, member of the Russian Expert Council and Accommodation and Refraction, and she introduced her talk about Duane syndrome, clinical course options, and treatment. And if you let me, I want to speak to say something in Russia for our colleague. Дорогие коллеги, я бы хотела вас попросить, что вы можете писать ваши вопросы, в том числе и на русском языке, в вкладке «Вопросы и ответы», чтобы вопрос не терялся, лучше писать все-таки не в чате, а в вопросах и ответах. И наши спикеры в процессе презентации будут отвечать, вы можете писать в том числе и на русском языке. И также вы можете, значит, менять язык, об этом написали уже в чате, для того, чтобы прослушать на том или ином удобном вам языке. Сейчас профессор Ольга Жукова с презентацией. Спасибо.
Today, I will tell about Duane's syndrome. This syndrome is named after Alexander Duane, which published a review article on this condition in 1905. And he referred to earlier publications by Jakob Stilling and Zygmunt Turk. And so this syndrome, the most ophthalmologists called Stilling-Turk-Duane's syndrome. This syndrome accounts for 1% of all patients with strabismus. Most cases of this syndrome are sporadic, although cases of familial autosomal dominant Duane syndrome have been described. In etiology of this syndrome, we can see two aspects. The first aspect, the Duane syndrome is a congenital condition, and the first aspect is a tight fibrotic lateral rectus muscle. And in 1974, Huber, in a study of electrical activity of the lateral rectus muscle, found its paradoxal activity during induction, as in a medial rectus muscle. Histological examination of postmortem preparation of patients with Duane syndrome showed that the lateral rectus muscle in them is innervated by the branches of oculomotor nerve. And wherever the sixth nerve and the its nucleus are abnormal or absent. And so the Duane syndrome thought to be a congenital misinnervation of the lateral rectus muscles with the branches of third nerve with the lateral rectus muscle contraction on the attempted adduction. And co-contracting of both medial and lateral rectus muscles on attempted adduction is thought to produce the retraction of the globe into the orbit. The clinical course options of this syndrome are different. There are 6 main symptoms of Duane syndrome. The first is the eye retraction during adduction. And so we can see restriction or complete absence of abduction, restriction of adduction of variant severity, and sometimes we can see a sharply oblique up or down movement on the affected eye on adduction, the neuron of the palpebral fissure on adduction, and the paresis or restriction of convergence of the affected eye. Also, in Duane syndrome, usually there is not amblyopia. The head tilt is present. Binocular vision is often present with head tilt. And Duane syndrome is often bilateral, but may be very asymmetric, so its bilaterality may be overlooked. The Huber described 3 types of Duane syndrome. Type 1 is the most often, about 80%, including markedly deficient abduction, almost normal adduction, and narrowing of palpebral fissure and retraction of the globe in adduction, and often accompanied by esotropia and head torticollis. Type 2 of Duane syndrome, characterized by normal abduction, adduction deficiency, narrowing of the palpebral fissure and retraction of the globe on adduction, and accompanying exotropia and also head torticollis. And the third type of Duane syndrome, characterized by restriction of both abduction and adduction, and narrowing of palpebral fissure, occurs upon attempted adduction. And on this slide, we can see a patient with bilateral Duane syndrome type 3. Sometimes we need a differential diagnosis between Duane syndrome type 1 and 6-nerve palsy. It is difficult because in 6-nerve palsy, we can see the restriction of adduction, but there is no the narrowing of palpebral fissure and no retraction of the eye, while in the Duane syndrome type 1, we can see the symptoms. As for surgical treatment, I have to say that many patients with Duane syndrome don't require any surgical intervention. They have orthotropia, good visual acuity, binocular vision, light head tilt, and they adopt with this condition and don't need any surgery. Our patients with Duane syndrome need surgery if they have a cosmetically unacceptable head posture, if they have strabismus and primary gaze, and occasionally if the vertical upshoots or downshoots is a cosmetic problem. Many ophthalmologists advise that only muscle recessions should be used in Duane syndrome surgery. We can recess both medial and lateral rectus muscles. The medial rectus recession used in type 1 syndrome, the lateral rectus recession used in type 2 syndrome, and if we have a severe retraction of the globe and anophthalmos, we can make both medial and lateral rectus recessions one time. Resections and temporal transpositions of vertical muscles should not be contemplated because the eye muscles are already tight and fibrotic, and the vertical muscles transposition does not increase abduction and worsen anophthalmos. And this is the clinical example. This is a 3-year-old girl with Duane syndrome type 1. She has good visual acuity, and we can see head tilt, esotropia and primary gaze, narrowing of the palpebral fissure, retraction of the globe on adduction and upshoot. This is a little girl, and she did not want to look right while I was made photos. I think because she had diplopia in this gaze position. We made a right medial rectus muscle recession, 7 millimeters from attachment point, and we use handbag technique for fixation of muscle because it was difficult to make posterior scleral sutures in this large recession. And this girl, 1 year after surgery, there is no head tilt, no exotropia, and we can see a happy girl. And so it is better to use muscle recession in surgery of Duane syndrome. Medial rectus recession corrects head tilt and esotropia. Lateral rectus recession reduces retraction of adduction and upshoots or downshoots. And sometimes extreme vertical deviations can be helped by small recession, about 3 millimeters, of adenization of vertical recti muscles. Thank you for your attention.
Thank you so much, Dr. Zhukova. I'm going to have maybe have Dr. Balasanyan do the discussion. Because of the delay and the glitch, I guess it wouldn't be a webinar if we didn't have a delay or a glitch. So thank you for your patience. And with that, maybe a quick 1 or 2 questions and we can move on. Thank you. It was a fantastic talk, Dr. Zhukova.
Thank you.
In our chat, we see only our colleagues say thank you, Dr. Olga, for the presentation. Olga, thank you again. We don't have any question. And may I ask one question? In cases after the first stage of Duane syndrome, after you performed the recession.
Hello, dear colleagues.
What's happened? Yes, and do you use the first step after the first surgeon for getting more avidection, while splitting or transposition? Do you use it in your practice or no?
Thank you, Victoria. I think that in Duane syndrome, we don't use transposition because I saw one. Oh, excuse me, please. Yes. Can you hear me? Yes. No. Mm-hmm. In Duane syndrome type 3, we don't use transposition because once when I was a young surgeon, I saw one case when transposition due to severe anaphthalmos. And we don't use it in Duane syndrome. We use just recessions.
Great. And with that, if you don't mind, I'm going to introduce our next speaker, which is also my co-moderator. And let me put this up real quick. And I think it's just a quick introduction already has been made. And with that, just to kind of save time, I'm going to start her talk with your permission.
Dear colleagues, good afternoon. Thanks for organizing such a great webinar between IPOSC and AOS. I am really delighted to participate in this event. And today we would like to present our work titled New Technologies in the Surgical Treatment of Duane Syndrome. Currently, the most well-known classification of Duane syndrome is Huber's classification. It divides Duane syndrome into 3 typical forms. Dr. Seyhan Ozkan proposed the addition to the atypical forms into Huber's classification, type 4, 5, 6. And also Kurana proposed to modify Huber's classification to adapt it for clinical and surgical practice. For this purpose, Duane syndrome was classified into azotropic, exotropic, and orthotropic forms. Our colleague, Ramesh Kennukekunaya, analyzed the available scientific works on the treatment of Duane syndrome, and he identified the most common tactics of surgical management of patients with this disease. Typically, in cases of azo and exotropical forms of Duane syndrome, the first step of surgery is a single or bilateral recession of the recti muscles. Other surgeons prefer to perform a recession plus resection of antagonistic muscles on one eye. The dosage of the surgery is determined according to the average statistical data of the recession volume of a particular angle of strabismus. The most frequent second step of the surgical treatment of typical Duane syndrome is the transposition of the superior and inferior recti muscles to the horizontally acting rectus muscle via the helix. In some cases, an alternative is the transposition of only the superior rectus muscle to the lateral rectus muscle. In cases of atypical Duane syndrome forms, patients underwent single horizontal rectus muscle recessions, while splitting of the lateral rectus muscle plus recession of both horizontal recti, recession of both horizontal recti in defective eye, and in some cases, recession of rectus muscle on normal eye too. At Professor Igor Aznauran's Association of Pediatric Ophthalmology Clinics, Yasnevzor, surgical treatment of type 1 to Duane syndrome is also carried out 2 stages. The first stage is deep recession of the horizontally acting rectus muscle on the affected eye for correction of the angle of deviation, and calculation of dosage of the surgery is carried out by the Strabismus system. And the second step, massive transposition of the superior and inferior recti to increase the degree of eye movements. On the critical aspect, one of the critical aspects when planning deep recession or horizontal rectus muscles in Duane syndrome is the determination of the exact angle of strabismus. The key point is the differentiation between the primary and secondary angles of strabismus, which can be especially difficult when both eyes are affected and when it is not possible to move eyes to the central position. However, a surgical intervention planning which is based on the correct primary angle of deviation measurements as well as correct dosage of the first surgical strap minimize the probability of residual tropias and the need of additional surgeries. In addition to the traditional methods of strabismus angle measurements, we use a video oculography, and the method uniquely allows to accurately assess the angle of deviation and the degree of eye movements. It also allows to study the eye movement under natural conditions. So the dosage of the first stage of surgical treatment is calculated according to a special mathematical formula derived by Professor Igor Aznauran. This formula considers the dependence of the angle of strabismus from the anthropometric eye parameters, the axial length, the transverse length of the eyeball, and the diameter of the cornea. A computer software performs modeling of the surgery considering patients' individual surgery dosage. Based on this data, the location of the eye equator and the amount of necessary muscle recession behind the equator are calculated. You can see how the program works. And studying the biomechanical basis of the effectiveness of the recession, we concluded that the outcome of the surgery depends on the location of the equator with respect to the limbus and the location of muscles attachment with respect to the equator. And if the recession is carried out before the equator, the muscle force application point doesn't change. So in this video, you can see the technique of deep recession using a low traumatic method. Conjunctival dissection is carried out by a high-frequency radio wave knife. Using this method allows us to avoid intraoperative hemorrhage and tissue inhibition with blood. This in turn prevents the development of pronounced scarring process in postoperative period. After isolating the tendon of medial rectus muscle, you can see on this video, we suture it at the attachment point. We make mark on the sclera, which correspond to the position of the equator with respect to limb, calculated by the Strabo program, and then measure the necessary amount of muscle recession behind the equator. Then, using the same threads with which we saw the tendon earlier, we perform the muscles recession. So then we cut the muscle by using radio wave knife too, and by creating nodular suture, we attach the tendon to the severed muscle to the new attachment point. So the operation is finished, and then after that, we suture the conjunctiva. So on this video, you can see the second stage of surgical treatment of Duane syndrome, the massive transposition of the superior and inferior recti muscles. After isolating the inferior rectus muscle, we suture it at the attachment point. Then we measure the tendon's width. After isolating the lateral rectus muscle, we suture to its tendon's inferior attachment point the corresponding end of inferior rectus muscle tendon. We mark the width of inferior rectus tendon on the sclera and suture the second end of the tendon of the inferior rectus. So using the radio wave knife, we cut the inferior muscle tendon and suture it to the new attachment point. Please direct your attention to our suture material. We always use big reel threads 7.0. Using such a thin suture material allows for high accuracy of the surgical interventions. So then we isolate the superior rectus muscle and suture it at the attachment point using Wright's hook. And this hook has a special channel which helps prevent damage to the underlying tissues, and to the superior point of attachment of lateral rectus muscle tendon, we suture the appropriative part of superior rectus muscle tendon. The other part of this tendon is sutured at a distance equal to its tendon width. And then we cut the superior muscle tendon by using radio wave knife tool and suture it to the new point of attachment. So we finish, and then again we suture the conjunctiva. So on this slide, you can see photos of our patient. As you can see on the cover test, the angle of strabismus is completely restored. And we have an orthotropy in primary position of eye, and you can also observe an increase in ambidextron of the right eye when looking to the right. And you can also see the increase in eye movement levels before the surgery and after both surgical steps. And here is the videos of our another patient with Duane syndrome on his left eye. And there are two videos. On the first, you can see his eye movements before the operation, and on the second, you can see how he does it now. So that's all. Thank you very much. Thank you for your attention.
Thank you, Victoria. Fantastic videos and a technique. Also, a very new software, at least not new for you, but new for the rest of the world. And I had the pleasure of seeing that from Dr. Aznorian directly and yourself when we had visited Russia. And just as a reminder, also a plug, there is going to be an IPOSC and an AOS joint meeting coming up as in a webinar format in September 11th and 12th. So I'm sure there's going to be more discussions in that about the program itself. Maybe we can take one quick question and then we can move on. Victoria, do you, yes, Natalia?
Thank you. I had just a question about deep recess of medial rectus. you put it behind equator. 7 centimeters, it means behind equator. In my opinion, I never made it because it's very dangerous for loose adduction. Do you have some complication, this kind of complication?
We don't have any patient with when we yes, I understand. Okay, we mean 7 millimeters. It's not behind the equator. It's about in some cases it is through 3 millimeters. It depends on the angle of deviation. And it is never 7 millimeters behind the equator. It is about usually equator, as you can see on this program, the location of equator, it is about 9-10 millimeters behind the limbus.
So I mean, be careful to put to make a big recession.
Okay,
Oh, yeah, I'm sorry.
we don't have any cases.
Thank you.
Much. Thank you.
And I have to agree that these numbers from the for lateral rectus, we can go way beyond that from the insertion as well as, and we have not seen, at least in my clinic, any restrictions in that. The medial rectus, 7 millimeters maybe slightly from the insertion cause a problem, but I have not seen that either. With that, we'll continue the discussion with the QA and the chat pod. Tamara, would you please share your screen? Fantastic. And I would like to quickly introduce our other fantastic speaker, Dr. Tamara Wygnanski-Jaffe from Israel. She's an associate professor of ophthalmology at the Sackler School of Medicine in Tel Aviv University, Israel. She's the chief of the Pediatric Ophthalmology and Strabismus service at the Sheba Medical Center in Israel, former secretary treasurer and head of research committee of IPOSC, a former chairman of Israeli Pediatric Ophthalmology and Strabismus Society. She's actually given so many things to IPOSC and our community. It's great to have you as always, Tamara. Thank you.
Thank you, everyone, and thanks for including me in this webinar. So let's talk about resections in thyroid eye disease. And in one word, do we like it? So I think all of us would agree the answer is absolutely not. But sometimes there's no better choice and no other choice, and we have to do resections in these cases. So I'd like to share with you a gentleman that came to my clinic several years ago. And actually, while he was waiting outside, I told him, I think you're in the wrong clinic because the oculoplastics clinic is just next to me. And he said, no, I was referred to you. And then he told you this heartbreaking statement that all thyroid eye disease patients tell you is that I scare people. I can't take off my glasses. I can't go outside. I can't even meet with my children or grandchildren. So he actually underwent several orbital decompressions already by the time he was referred to us. And he had absolutely no ocular movements at all. We measured him with Krimsky alone, and we decided on what muscles to do on surgery based on the MRI alone. And he already underwent on this first surgical procedure. We decided to do address the esotropia with a medial rectus recession and a lateral rectus resection in the right eye, and to address the hypotropia with an inferior rectus recession and a superior rectus resection in the left eye. So here we did resections on both verticals and horizontals on the first surgical procedure, and this is how he looked the day after. A lot of epiphora, a lot of irritation, but he was, with time, very happy. And over the years, he had a recurrent esotropia in the left eye, actually in the eye that didn't have an enlargement of the medial rectus at the time. And we did a medial rectus recession of 6.5 millimeters. And although he could not elevate his eyes almost at all, his horizontal movement was very good. And he was orthophoric for both distance and near, a little bit of left over right, which at the end was right over right hypotropia at the end, but he was very satisfied at this time, and we'll see what happened with him later. What about the verticals? So when you have a case like this, it's actually the easy or nice garden case, because you have bilateral involvement. You could do a recession in the left eye of the inferior rectus and a recession in the right eye of the superior rectus. And this is actually the best thing you can do for these patients, both recessions. And that's a very, very good solution, one of the solutions we like best. But what do you do in a case like this? This patient has monocular involvement. This eye is perfectly normal, and this eye has a huge hypotropia. Look at this patient, same story. She has a unilateral involvement, and look at the inferior rectus here compared to the inferior rectus here, which is normal. And she even tells you, no one is not touching my right eye, and no one is examining even my right eye. I'm not having it touched. So she actually had an inferior rectus recession together with the superior rectus resection on the first surgery, and it turned out well for her. What about a patient like this? Well, when you see this patient, you say, okay, I'll do BMRs. But looking at the letter, if she comes with her, you find out that she already had supramaximal BMRs performed, but she's left with a residual esotropia, not a recurrent esotropia, of 60-65 at both distance and near. So what would you do here? Would you resect the lateral recti, or would you not? So there's literature about resecting lateral recti and horizontal deviations in thyroid eye disease. There's a nice article by Oscar Cruz, who resected residual esotropia with lateral rectus resections, and it turned out well. And the same by Natalie Kerr. These both were done as second procedures. There's also an article by Eric Steele, who performed a recess resect on the first surgical approach. How about verticals? Same thing. With verticals, it might be more common. And if you have unilateral involvement, you would like to recess resect the involved eye. And these two articles do show that. And this is another article that shows what we had actually done is recess and resect for both verticals and horizontals in the primary surgical approach. There's actually a high rate of success in vertical surgery if the vertical deviation is over 20, and not all of us like putting the inferior rectus where it goes once we detach the muscle. Some of us like knowing or having more control on where the muscle is. And actually, you can have good ocular motility after doing resections. Conventionally, in all restrictive strabismus, we think the best thing to do is recess the muscle. That makes a lot of sense. You have something tight, you want to recess it and make things weaker. And we know that from Duane too. Most of us do recessions in Duane's or transpositions, but it has been shown by Steve Kraft that doing resections on the lateral rectus in well-indicated cases can be of benefit as well. There's also concern about further limitation of ocular motility of extraocular muscles in all restrictive strabismus, but surprisingly, that is not always what turns out to be. We also worry about consecutive exotropia, especially in restrictive strabismus and mostly in thyroid eye disease, and we're reluctant because if we do bimedial recessions and if we have strong laterals, they may turn the eye outwards and we will end up with both consecutive exotropia and also very bothersome convergence difficulties. But what do you do after you perform maximal recession or supramaximal recession and you still have a residual esotropia? And that also causes a lot of bothersome symptoms such as astinopia and reading difficulties. And all these patients are symptomatic and complaining, not only of diplopia. And here you go again. We know that sometimes or many times after we do surgery for thyroid eye disease, we have binocular problems and we use prisms many times, but many reports actually have shown that resection in indicated cases with large deviations causing diplopia, monocular patients refusing bilateral surgery, or residual undercorrections despite maximal recession surgery can actually work well for the patients. The benefits of resection can be that it prevents displacement of the center of rotation of the globe. Actually, those worried about post or worsening inflammation in thyroid eye disease, that has not been shown. And there's no increased restriction, which I find quite surprising, because you would think that if you do a restrictive procedure in a restrictive disease, you would actually increase the restriction and minimize ocular movements, which does not always turn out to be the case. We know that after orbital decompression, especially the medial wall, the success of thyroid eye surgery is less good, strabismus surgery is less good, and it's very different from decompressing the lateral wall or inferior wall, which is done many times for cosmesis. So we also know that strabismus surgery is less successful the more involved the orbit is. So if you have, the larger the muscle is, the more proptosis you have, and the more restriction you have, your success rates will be lower. You should definitely avoid resection in muscles that look like this. That may not be a good idea, and try to use the muscles that look as thin or as normal as possible. And I always think it's a good idea to wait, although these patients don't like waiting, they look horrible and it's very disfiguring, but you can use MRI and know which patients are active, and it's preferably much better to do surgery when they're inactive. So on imaging, you don't want to use or do resections on these huge muscles. You'd prefer to use the smaller ones, and then you would get more predictable results. So in conclusion, thyroid eye disease is very challenging. It's really hard to get rid of the diplopia, but prisms can help us there. But in selective or well-selected patients, it may be safe and good to consider resections as well. So we can do the laterals and we can do the superiors. And although we like to use recessions, this can be another add to our toolbox. And definitely we need to remember that although we worry so much about overcorrection and restrictive strabismus, and namely in thyroid eye disease, most of the failures at first stage are actually undercorrections and not overcorrections. The overcorrections come later on with time. So let me share with you our patient that we did surgery about 10 years ago. And today he has a small right hypo, and he does have a convergence insufficiency. You can see that his habitus has changed completely, and we want him to use prisms for reading, but he refuses to use either reading glasses or prisms. And you can see that his eyes can move nicely now, although there was no ocular movement when we started out with him over 10 years ago. And finally, I'd like to just say that the present and the future should probably be molecular or drug modifying drugs such as teprotumumab. And you can see here that this is a placebo use and there's no change. This is a patient that received the drug, and you can see the difference in the proptosis and the inflammation. And here you could see the baseline medial rectus and inferior rectus, and look how it's changed within 6 months, how the muscles look so much more normal. So that may be the future for our thyroid eye disease patients, and hopefully that will give them hope and a much better future. So thanks so much for having me.
What a great talk, as always, Tamara. And a quick question: that there are some questions coming up in the Q&A, but I was going to ask about the teprotumumab. You've been using this, and you alluded to that. Do you think the muscles are different? Do they normalize, or are they still stiff? Or did you end up doing any surgeries after the teprotumumab? What has been your experience?
So we don't have a lot of teprotumumab patients here. Most of them are referred to the publication in the New England Journal of Medicine, and there was a big article in the AJO about it. I'm not sure the muscles normalize, but definitely their size is totally different. It's hard to say if muscles after thyroid eye disease have the same elasticity they would have normally, but definitely looking at these patients and what happens to them gives a lot of hope, and it's probably the better way to go without all those orbital decompressions and all the strabismus surgery we do, and that really brings new future for these patients. And hopefully all around the world, we'll be able to use these drugs to really modify the disease.
It really has been. And so there's a question they're asking about how much recession do you do for the inferior and superior rectus and the hypertropia?
I think it really depends on the grade of it and how you normalize your force reduction test afterwards, or if you can normalize it at all. But for me, I at least do adjustable sutures whenever possible in all thyroid eye disease patients. So I always have a second chance in correcting it. And I think the most important thing to do is to leave them slightly undercorrected and never overcorrected.
Okay. And I'm going to invite actually many of the people who are listening, the experts in thyroid eye disease and orbitopathy, especially Sonal, Seyhan, and many others that I can see that they're there. Please feel free to comment about your experience in Tepezza in particular, or post Tepezza. I'm going to quickly now go to our next speaker for Victoria to announce, and we will hear Natalya Popova talk after that.
Yes, Natalya Popova from St. Petersburg, professor, honored doctor of Russian Federation, head of ophthalmology department in Clinic Scandinavia in St. Petersburg, vice-president of Association of Ophthalmology and Strabismus in Russia. She tell us about Seyhan-Brown syndrome. Natalya, thank you.
Dear colleagues, today we will speak about Brown's syndrome, most difficult condition for diagnostic, differentiation, and treatment. A lot of cases with strabismus looks like a paralytic strabismus, but complex of symptoms can help us to understand this condition. In 1950, Brown described a congenital eye movement disorders due to a tight tendon sheath and called it superior oblique sheath syndrome. But today we know that pathology located is not sheath of tendon. It can be in trochlear field, inside trochlea, pretrochlear, and posttrochlear portion. It makes tendon tight and it make movement disorders. Clinical features: limitation of elevation in abduction, downshoot in abduction, divergence in upgaze, V or Y pattern, absence of superior oblique overaction, abnormal head posture, chin up with head tilt, and positive forced reduction test. In this case, you can see right eye has a limitation of elevation, mostly in abduction. And this girl has a V pattern. Forced reduction test helps us to differentiate Brown's syndrome and inferior oblique palsy. Inferior oblique palsy can limited to upgaze movement also, but duction test will be negative. Positive duction test indicates to Brown's syndrome. we use adduction torsion test. It must more useful. Hold the globe at 3 and 9 o'clock position, push it to orbit to stretch the tendon, and try to extort the eye. Impossible globe extortion indicates to Brown syndrome. Adduction torsion test is positive. So we know tendon and sheath superior oblique or trochlear are responsible about this condition. But where is a point of anomaly? It's most difficult question. Where is pathology located? Every case is unique case. Brown syndrome can be congenital, acquired due trauma or inflammation, and intermittent. Intermittent cases is most mystery cases. We would like to share with you with our cases. Congenital intermittent Brown syndrome. We observed in 4 patients with spontaneously improving of eye movements after strong blinking or pressing of globe by finger. Movement restored immediately, like a click. We found in publication a term, click syndrome. In publication Rupert Hall, the superior oblique click syndrome, when we can see spontaneously improvement of movement with an audible click, named superior oblique click syndrome. Management of Brown syndrome. It can be conservative and surgical. Conservative, it's for cases because inflammation, but for congenital cases, it must be surgical, surgery. Indication for surgery: hypotropia in primary position, anomalous head posture, loss of binocularity, and surgery includes weakening procedure of superior oblique tendon or sheath or anothers. It includes complete tendectomy or superior oblique recession or tendon lengthening procedures. For recession, we use a supratemporal approach, but for tenotomy or lengthening procedure, we use supranasal approach. Look at left eye. We hook a rectus superior muscle and hold it. Then, by another hook, we looking for nasally superior oblique tendon. It can be very difficult task because very tight tendon sometimes cannot move this hook, and it makes impossible to some procedure, weakened procedure, except the tenotomy or tenectomy. When you hook a superior oblique, please control yourself. Normally, we put a finger to the trochlea and push and pull, pull by hook suspension superior oblique. Why suspension? Because superior some tissue, periorbital tissue, can imitate, simulate oblique tendon. When you push, when you pull by hook tissue, you can feel by your finger intraocular that is original oblique superior tendon. And then you can make what you planned. Beginning and ending of surgery have to be controlled by torsion test. We start surgery and finish surgery by duction torsion test. Let me introduce you some samples. First samples, girl with right eyebrow syndrome before and after surgery. We perform the loop tenotomy of superior oblique with non-absorbable suture. Another case, when we make tenotomy, the right superior oblique, we could see, of course, improvements of movements, but overaction of inferior oblique appear. Next steps, we made inferior oblique weakening, recession of inferior oblique, and we had a good result. Normally, we expect, and after tenotomy of superior oblique, overaction of inferior oblique, but next steps helps us to restore good balance. Thank you.
What a fantastic talk. Thank you for the details. And I'm going to have Dr. Balasanyan lead a discussion. Are there any questions from the audience?
Don't have any questions for
May I have a question?
Go ahead, Seyhan.
And Natalya, thank you very much for this comprehensive talk. I would like to learn your opinion about how long do you wait for the possibility of spontaneous resolution, or maybe I must ask whether you are going to wait or whether you are going to do the surgery, because in our experience, in those who do not desperately need surgery, they may show spontaneous improvement if you wait long enough. So this is our observation, and that's why I asked this question to you. What's your experience on that in your patient group?
Thank you, Seyhan, for this question. Yes, it's a very important question. What we have to do if this movement restore, improved so quick. In my practice, 3 patients were refused from surgery because they told, I recovered myself, just push by finger my eye. But one girl, now I look her perhaps 6 months, maybe more, and she became worse. This Brown syndrome became worse. So I plan to make surgery for her. I prefer to make tenotomy. Of course, it's not good from it's not good from physiology, because we disinsert muscle and tendon, but sometimes we cannot do nothing. And in my opinion, I think that majority of Brown syndrome looks like local congenital fibrosis syndrome, when we cannot make nothing except tenectomy. Thank you.
Great. And if there's no other discussion, maybe we can quickly go to the last.
Yes, and I'm proud to introduce the next speaker, Professor Faruk, with his talk, glaucoma surgery related restrictive strabismus. Thank you.
Thank you. It's a pleasure to be here, as mentioned before, and I'm going to speed up a little bit and just to catch up on time. And I apologize if I go too fast, but I have no financial disclosure for this talk. This is mainly more geared towards the glaucoma surgery related restrictive strabismus, but what I'm going to talk about does apply to many other surgeries, including retina surgeries when you have scleral buckles, or different surgeries around the eyes that are done not only by the strabismus surgeons, but particularly by other modalities that you had to do. It can cause anything. Actually, all the procedures can cause restrictive strabismus in particular for various reasons, as you're seeing, and it can cause different variable types of strabismus or in combined. A few examples. This is actually a trabeculectomy and related restrictive scar, so it can happen. This is a tube shunt. In this case, it's not only vertical, there was a horizontal restriction because it was involving the lateral rectus as well as the superior rectus complex, along with the oblique as well. After tube shunt, and another gentleman, this is purely vertical, and as you can see in the up case, had a better look, but looking down was restrictive. So it can come in different shades, and various pathology, it does happen. So the vast majority where the tube shunt is being put, and that's what we vast majority see the problems with glaucoma surgeries causing strabismus, is put into the temporal and lateral aspect. So the superior temporal aspect between the superior rectus and the lateral rectus. So that's where it tends to be the problem, including the superior oblique too. In our clinic, before we go to the surgeries, we'd like to look at the scar tissue and the complex. If we can see it, it is fairly posterior. You need to really infraduct the eye to see this, but it gives us some idea on what's going on, because these could be very complex problems, and we try to look at the scar tissue. And the scar tissue could be significant enough that it looks almost like a cardboard that you're really cutting through. These are, again, fairly, could become very complex in that sense, but be ready to really see these tissues. That is not only involving the tube shunt itself, but also the muscles, and so gentle dissection all around is crucial. This also becomes a convenient time to maybe revisit the tube shunts occasionally. Again, restrictive doesn't, it happens in any age, but I dare to say, I think I see it a little more in kids because they scar amazingly more. And even in the same patient, as you're seeing here, that you can see the outline on the right eye, which is you see on your left side, you can see the outline of the tube and the tube shunt, but on the in her left eye, the cystic component in the scar is so significant that it's just the tube shunt or the plate itself is not even visible. A quick video about the particular surgery for this patient. I'm going to speed up a little bit. So again, the one thing I have to say is these surgeries, I would advise a very experienced strabismus surgeon as well as a glaucoma surgeon going into the cases together. That's what is generally done. I happen to be dealing with glaucoma itself as well as the strabismus, so I do it on my own, but these could be very difficult cases. So be ready to be maybe even removing the tube shunt or repositioning them if that comes to that. And same goes along with the trabeculectomy bleb. So you have to be very careful on what you're dealing with. Gentle dissection all around is crucial. One thing I did do at the beginning of the case was to inflate the anterior chamber with viscoelastic. That is crucial, and because as you can see, as we introduct the eye, you just don't see what the anterior chamber is doing. So that tamponades that area. But not only that, as soon as you disrupt the cyst itself, obviously the pressure is going to go to close to zero, if not zero. So you have to have that kind of a buffer there, and gentle dissection all around to really dissect the plate itself from the different tissues, as well as the globe itself is crucial. Then understanding, and throughout the case, doing forced ductions really helps you to understand where you are. Sometimes it's just the scar tissue, sometimes it's just the bleb itself, sometimes it's the muscle involved. So every so often one has to do the forced duction. In this case, we did actually end up recessing the muscle, which you haven't seen here, but as well as remove the extensive scar tissue, which was seen with the forced ductions too. Tube can have a mass effect, so that was a restriction, but sometimes the restriction is because of the mass effect. And in this case, there's this amazingly big cystic bleb there, and just again a quick video on how it looks like. In this case, we ended up dissecting the conjunctiva off the cyst initially. Again, very gentle, good dissection is all you need to really delineate the tissues of conjunctiva and the cystic bleb itself. Then comes the disruption of the cyst itself that you'll see right here. And removing the cyst altogether generally does the trick. Again, looking with the forced ductions to make sure that actually has released is the key to go. And then all you do is just suture this up and close it. And again, these are complex surgeries, need experience in complex muscle surgeries, need experience in various glaucoma surgeries. And obviously, just like previously Seyhan had mentioned, you need magnification. You simply cannot go into these surgeries with inadequate magnification. You need to see every detail and be prepared to undo, redo glaucoma surgery. And as I mentioned, the key is also to maintaining the AC prior to disrupting the bleb and shunt reservoir. And spasiba for allowing me to be here and having a quick. I'm going to stop this to be a part of this session. Any questions regarding this? Or actually at this time, maybe we can talk about any other questions about overall of any of the talks that we have received.
And may I ask a question to you, Faruk?
Of course, yeah.
Thank you for this excellent talk. And so these are, well, very amazing and very difficult surgeries, as you mentioned, and congratulations for that. And but while I was watching your presentation, I thought that this patient group could be a good candidate to try for toxin injection. I mean, considering the complexity of the procedure and considering the possibility of making the glaucoma worse, and considering to find a glaucoma specialist and a strabismologist, where you're lucky that you're doing both, but it's not always the case for the ones like me. I would suggest to go on with toxin, especially in the early period, but even in a late period, it may, I think, work in some at least, similar to retinal detachment surgery results. But the point may be that considering that there was a question and answer section part, I want to remind that in this group of patients, the toxin should be done with EMG, not with grasping, because when you try to grasp something, even for an Ahmet valve something, you may disturb the original implant.
And points well taken. And I do not have any experience in that, meaning I've never did a Botox, and I will, simply because of the complexity, and especially if the pressure is particularly doing well in that patient, then you're going into this area that a working bleb or shunt may not be the best idea. You're absolutely right in that, and I will use that. The only thing I would say is if the scar tissue is extensive, it will be difficult to find the muscle. Then you're kind of poking around a little bit, and one may need to go in to find the muscle first anyhow, and that takes some extra experience too. But I haven't had any experience, and I welcome the thought for sure, and I will be trying that as well. Any other last comments or questions or comments about from any of the panelists in particular?
Can I ask Victoria, I know you used your model also in esotropia. Igor has shown that several times, and it was very impressive. So do you think this model fits all types of strabismus, not only Duane or congenital esotropia? Would you use it for any mode of strabismus, taking into account other factors that we don't usually account for in strabismus surgery?
Yes, sure. We use it in all types of, horizontal strabismus, no vertical, expecting vertical. We use it in esotropia and exotropia too, not only in Duane syndrome.
And your calculations need the axial length of the eye, and you do
Axial length, yes, cornea diameter, and in cases of hypertropia, in cases, yes, in hypertropia, we use it, the degree of +2 and +5, and it change the dosage of operation. It depends not only of axial length, of cornea, and it's depend hypermetropia, I mean.
And so that for people who don't know what we're talking about, it's the fantastic program that Victoria had presented, and Dr. Aznoyan had come up with this program, that you plug in all these parameters, including the deviation of the eye, and the program tells you how much to recess or do the procedure. So this is a calculation method that they have been using in their practice for quite some time, and hopefully we'll hear more about it. Any other comments? Any other last minute questions?
And may I ask a question to Tamara?
Yes.
And Tamara, thank you for the very nice presentation. And I would like to ask your opinion first. Would you consider doing MRIs before going on resection surgeries in thyroid eye disease patients? Because sometimes they may have subclinical activation, that the clinical activity score may be 0, but you may find some activity in MRI. And the second part of the question is that, you know, these patients usually require both vertical and horizontal surgery. So when you do a resect, another concern could be the anterior segment ischemias, considering these are thyroid patients. Do you consider some specific precautions like vessel sparing or something else? I'd like to learn your opinion and your experience on that.
A lot of questions, but briefly.
Okay, so the first question, yes, we do perform MRIs on all of our patients. Basically, lots of our patients are post decompression, maybe not even once, maybe more often. So yes, they do have MRIs, and also it's, you know, some of these patients are very impatient to have surgery, and if you do an MRI, you can delay it a little bit, and that's also a good factor. And it also gives you a lot of information about what muscles are involved, how much, and if there is activation or not. So that's part one. Part two, regarding anterior segment ischemia. So in thyroid eye patients, that's less of a worry than in other types of patients, because they recover, or the vascularity recovers more. And I wouldn't do more than probably 4 muscles on one session. And many times we do only one muscle, but someone asked me regarding plications in thyroid eye disease, and I do not have experience with that, but I don't think I would plicate a muscle that does not look normal. But again, I don't have experience with plications in thyroid eye disease patients.
Thank you. And with that, I would like to quickly say special thanks, spasibo, to particularly Sati Agagulian, and she has been a force behind the entire webinar coming to this point, and obviously Jason Yam, Igor, and Sonal Farzavandi. This wouldn't happen without your great efforts. Also, a special thanks for Maxim Sirenko. He has been our simultaneous translator. This is the first webinar that we have actually had two languages spoken at the same time, and he is just it was amazing. So thank you, Maxim. As always, we would like to thank Daniel Mummert and Michael Ray for their unwavering technical support, and obviously all the speakers, and my lovely co-moderator Victoria Balasanyan for being with us. And again, it's great to have you all here. I would like to turn it over quickly to Jason to announce our next webinar. It's all you, Jason. You can unmute.
Sorry, can you see the screen now?
Yes, we can.
Yes, it's my pleasure to announce our next webinar. This time is on September 26th, which is a Sunday. So it is on the same time here as of today. So we have the topic is on congenital cataract. This time is with Indian colleague, the SPOSI, the Strabismus and Pediatric Ophthalmological Society of India. We have the staff faculty as always. We have Chris Loy from UK and also Professor Vinita Singh from India to moderate for us. And we have a speaker from India, the Siddharth Agarwal for clinical tips for beginner, Dr. Samantha Adaka for posterior capsular management, Professor Edward Wilson for secondary IOL placement in the back or in the ciliary sulcus, and Professor Sanderson Coker for surgery in the microophthalmia, ophthalmic, and ROP eyes, how to get it right. And Professor Jan de Faber from Netherlands on the HPV, PFV as a cause of congenital cataract to treat or not to treat. And also Professor Songpik Chi from Singapore on the management of pediatric subluxed lens. So please mark your diary and to mark the day, and we look forward to have you all in the next webinar. Thank you.
So with that, and with the permission from Victoria and the AOS team, I would like to conclude the program for this webinar. Thank you for your patience. And while we were going through some technical issues, but it was an excellent presentation and a webinar. Thanks to all our speakers, and it was great to have you all. I'm going to, while we conclude this, I'm going to have all the panelists and the speakers to maybe turn on their videos for a final picture as a memory to all. But please feel free to log out anytime aside from the speakers and the moderators. Thank you.